whole lot of topics are there in connective tissue disorder. The problem is that the patient may present with so many symptoms. It may be simple fatigue only, maybe headache only, the loss of weight only, loss of appetite. So many ways can present. That is why people think on their own aspect, like if this headache is there, it may not be the autoimmune disease, this will come into their picture. So that is a problem, but so many things are there. I try to, SLE is there, sclerodermas, Sjogren, so many are there. Let us try, start with a case. It's in fact a 35-year-old lady with 2-year history of a bluish discoloration of the hands while washing and on exposure to cold with pain and numbness of the finger. 3 months later, she developed a multiple joint pain involving small joints and also had morning stiffness. Since last 6 months, she developed a skin rash over the face, parotid swelling was there, the dryness of the mouth was there. She also noticed difficulty in climbing the stairs and getting up from sitting up position. This was evaluated by many physicians out there, and nobody could find out because there is a whole basket of things. There are bits and pieces from so many diseases. The patient is having the Raynaud's phenomena is there. Patient had some features of Sjogren's is there. Patients had features of rheumatoid is there. Patient is having features of some scleroderma is there. Finally, the patient landed to a rheumatologist, and he asked the first investigation was an ANA positive. He had the diagnosis, and patient is now doing fine. Let us see what. The commonest connective tissue disorder we come across in clinical practice is SLE. Always you think it's a very, very dangerous disease. If you look into the literature, 20 years survival is 75% of the patient, unlike the other disease. Because this is discussed or diagnosed much earlier than many of the other diseases. That is why the 20 years survival, unlike the other disease. This is, it is 90% of the cases you will see in the female is a multi-system connective tissue disorder. You divide the SLE as a word. Systemic means it is a multi-system disorder. Lupus means the wolf. And erythematosus means reddish erythematous rashes. What you are seeing the wolf, just imagine the wolf biting on the face of an young female, creating a butterfly rashes on the face. And in a systematic manner, that wolf keep on biting the rest of the part of their body. What is that wolf? The wolf inside that lady, it is that autoimmune. Normally what happens when a bacteria or virus enters the body produces the antibody, and it will be, the macrophage will destroy the antibody. What happens in the SLE? When there is an ultraviolet rays, you imagine the ultraviolet rays falls on the person. The cells undergo a programmed cell death. It is called the apoptosis. So the cell will be destroyed. The nuclear material will be released in the circulation. So normally this will be taken up by the macrophages and will be cleared from the circulation. But in the SLE patient, they are genetically predisposed for this disease, they will have a deficiency of a complement called C3, C4 complements are there. That is required to remove the apoptotic body from the circulation. This won't happen in the case of SLE. So the nucleus will be in the circulation. So this nucleus, what happened was the body identified as foreign, and body started generating the antibody against this nucleus. That is called the anti-nuclear antibody. This gets deposited in the various parts of the body. That is, the first thing is it goes to the blood vessel which produces vasculitis. It keep on attacking most of the parts of the bodies. Okay. So the areas where which is very interested is the area with the high vascularity, the brain, the skin. That is why skin got a very much vascularity. This get deposited in the skin, the brain, the heart, and the kidney. These are the common sites, but any sites in the body, the antibodies get deposited. So 95% of the persons will have a the diagnostic criteria, the skin problems are there. The skin, you can have an acute, subacute or chronic. The acute means something which happened in less than 1 month, subacute 1 to 3 months, or anything more than 3 months, we call it as a chronic. Okay. So the most commonest thing is the butterfly rashes which you see on the faces. Actually, it is a raised, usually flat or it can be raised. These immune complex can deposit it between the epidermis and the dermis there, so you can have an elevated lesions. And always something is there, the vasculitis is there, some amount of ischemia is there. The central pattern, sometimes you will get the pallor things will be there. Okay, so that will be a malar rashes will be there, that will be sparing the nasolabial fold. It can also produce the macular lesion, the papillar lesion. There is something, the epidermonecrolytic lesions also can be produced. The most important thing is the photosensitivity. You will see more than 25 hours, the lesions will be there. That will be the flat macular lesions, the diffuse lesions which may be seen. That is one of the commonest acute lesion, but always think of malar rashes. This is the one thing. Forget about the subacute. The chronic one, always concerned about the discoid lesions, which usually see on the face. The central area of usually seen above the neck. This is called the localized discoid, which will be seen above the neck and usually on the near the ear. Okay, that's what see. And there's a discoloration of the skin also. You'll see on that. There are other verrucous lesions. And so there are chilblain lesions, so many other lesions you can be. But one of the chronic lesions, it's a diagnostic criteria also, you can have a discoid lesions on the face. And the third thing is the acute skin lesion, the chronic skin lesion, you can have the alopecia. Alopecia means there's like lupus hair, it's called. It can be pinched off very easily, it can be broken very easily. That's alopecia is there. The peculiarity of the arthritis also is there in SLE. It is a non-erosive arthritis. You won't have that type of the difficulty you will see in rheumatoid arthritis. There is no deformity will be there in the case of SLE with the arthritis. They say non-erosive arthritis, where there won't be any joint deformities there. Usually you will see on the hands, the metacarpophalangeal joints are the commonest one which is involved. Okay. So the fifth one is the oral ulcerations. Oral ulcerations, you see, the peculiarity is that this is the painless ulcer. Painless ulcer you will see on the lips, on the cheek, on the tongue, on the hard palate, on the nasal septums also you can see. The peculiarity is the painless ulcer in the mouth. If somebody comes with the painless ulcer alone, you can think of the possibility of an SLE in this patient. And other thing is the serositis. Serositis means a triple P. You can have the peritonitis, you can have the pericarditis, you can have the pleural involvement. The commonest one is the pleura, the pleurisy. You can have the pleurisy, you can have the pleural effusion. There are other lung lesions like you can have the ILD, you can have, there are rare cases you can get a stringing lung syndrome, something like that thing you can get in the lung. When you go to the heart, the commonest one is the pericarditis, but you can have the pericardial effusion, you can have, there is an endocarditis called the Lippmann-Sack endocarditis. These vegetations get deposited in the mitral valve is the commonest one, you can get also on the aortic valve. This is on the ventricular surface of the mitral valve, you will get the vegetation that will be called the Lippmann-Sack endocarditis. You know, the patient may present with an abdominal pain only. This is called the medical peritonitis. So, one of the diagnostic criteria is the serositis. And also, as I mentioned earlier, there are areas where with a high blood flow, this will be there. The patient may be having a behavioral problem, but most concerned thing is patient may present with a sudden onset of seizure. Sudden onset of seizure may be a diagnostic criteria. It goes higher up, the patient may be having a higher risk. They can have the patient may be having the confusion, the depression, the anxiety. The patient have demyelinations. The patient can have the chorea, so many things. The neuropathy, mononeuropathy. All these, whatever things in the medicine, that can be there in the neurology. But headache is one of the commonest complaint of the SLA patient. Another thing is you are also always concerned about the seizure this is developing in this patient. 50% of the patient, this is the commonest cause of death also, as everyone knows. 50% of the death in SLE happens due to the renal failure. Patient may be presenting with hematuria, proteinuria, or maybe a higher BP, the pedal anything the patient may comes to you. This immune complex can deposit in the mesangial area. It can deposit in the end. It can be deposited in the basement membrane. Basement membrane can be deposited. It can be on the epithelial surface. So what you call it as a lupus nephritis. Lupus nephritis is one of the dangerous things. It can be having a minimal, that's a stage 1. The class 1 you can call the minimal, where you don't see anything under the microscope. The patient may be having a small amount of the mesangial cells will be there, and it's called the minimal. Where the microscopy not changes, only in the electron microscopy you may get some. Okay. And the grade 2 is the diffuse mesangial, where also a lot of mesangial cells were there in there. And the third stage is a focal glomerulonephritis. Less than 50% of the glomeruli, it will be deposited with this immune complex get deposited, less than 50%. And the fourth one, which is much more dangerous, is more than 50, that's diffuse glomerulonephritis. The third and fourth are the things which we are always concerned. And it can get deposited in the epithelial, that's called the minimal changes or minimal change glomerulonephritis. And when it becomes the 90% of the glomerulus get deposited, that is called glomerulosclerosis, 90%, that patient will be in the end-stage renal disease. This is the cause of death or the complications when you come across in the clinical practice, the renal problems are there. These, what all we mentioned was the type 3 hypersensitivity. The immune complex gets deposited. But it can also have a type 2 hypersensitive reaction that can also happen in the case of SLE patient. Where, you know, the ITP where the immune complex gets deposited in the platelet. When it travels to the spleen, where it will get destroyed in the cord. That's a splenic macrophage get destroyed. That is a type 2 hypersensitive reaction. Here also, the patient can have the pancytopenia, there's anemia can be there, leukopenia can be there, thrombocytopenia can be there. Or it is called the pancytopenia. This is also a type 2 hypersensitivity reaction. This is a cause of the leukopenia, pancytopenia is a commonest, one of the cause of the death in this patient because they were prone for opportunistic infections. That can produce, the patient may be on a treatment for a hypertension, patient may be on a hydrolysis. After sometimes patients comes with a joint pain. Don't treat with an analgesics. Instead of that, what you can do is stop the drugs. The drug-induced lupus. The drug-induced lupus. The commonest one is the hydrolysin or INH, quinidine, procainone. So many drugs can be cause the drug-induced nephritis, drug-induced lupus. The difference is that in the normally 90% of the people are the females and the 10% is the male. But in the case of a drug-induced SLE, 50% is there. And the patient doesn't develop the complication like the renal problems or other neurological problem. What happened in the, and if you stop the drugs, the patient will be recovered. So what we are mentioned was the diagnostic criteria. There's 11 diagnoses. SLIC has come out with the International Association, SLE Association with Collaboration Council. They come out with that 11 diagnostic criteria is there. You need to have 4 to make a diagnosis of either one clinical plus one immunological criteria should be there for diagnosing an SLE. So that's acute skin lesion was mentioned, the chronic skin lesion, the oral ulcer, the alopecia, arthritis, cirrhosis, renal dysfunction, neurological, all we have mentioned. The patient can have the hematological abnormality. What about the immunological? Okay. We've got so many immunological things. What we mentioned was the immunological things like the first thing is the targeted one is the ANA, the apoptotic bodies, they will produce the nucleus. It is getting attacked on the nucleus, it will produce ANA. Within the nucleus, you know the double stranded DNA is there. It also get attacked. So you will get a dsDNA positive. It can be there. There's an RNA is there. RNA will produce the split antibodies also can be positive. The patient can have on the cell wall, the phospholipid membrane is there. There are antibodies. There are 3 types of antibodies you see on the phospholipid membrane. There's a lupus anticoagulant. Coagulant is there. You can have the cell membrane, glycoprotein GP1 is there, lupus anticoagulants is there. These are the few antiphospholipid antibodies are there. This is very important because the patient can develop the APs, antiphospholipid syndromes can be there. The patient usually in the pregnancy you can get the antiphospholipid syndrome. These antiphospholipid, that's a cardiolipin antibody which gives a false positive for the VDRL positive. The cardiolipin, glycoprotein GP1 and the lupus anticoagulant. These attacks the uterine artery. It can get deposited. So the patient during pregnancy, they can have a recurrent abortions can be there. So only thing is that SLE is a disease we can have, the flyers will be there and remission is there. So the patient should be at least 6 months on remission only, you advise for become pregnant. And if there is one episode of the thrombosis is there, you advise for the anticoagulation. Not in pregnancy, you go for a heparin, and otherwise you go for the warfarin. That is the one we usually does. And these thrombosis, the males get more of an arterial thrombosis and females get the venous thrombosis. That is and the patient can develop the widespread thrombosis also can be there in the antiphospholipid syndrome. The diagnostic criteria, the patient can have the skin problem, can have the arthritis, the ulcers, you can have the pleuritis, the pericarditis, the nephritis, it can be there. Okay. One of the most sensitive investigation is the ANA and the most specific one is the double-stranded DNA. Smith also is a very sensitive investigation. So this chart is very useful. And ANA is seen in 98% of the patient, dsDNA is only 70, but it is very, very specific. You can have the Smith, and we'll come to that. Okay. So, our patient had the skin lesion, our patient had an arthritis, but ANA positive was. These are 3 things. We need to have making a diagnosis of an SLE, we need 4 or more criteria. So, the patient doesn't fit, dsDNA was negative and all other investigation was done for the patient and it is not the case of an SLE. Okay. So, what else it could be? The patient gives an history of dryness of the mouth, the parotic swelling. Is it a Sjogren's? Sjogren's is a very, very funny thing. The patient, it is very difficult. The patient cannot cry because they cannot have the tears. Patient cannot spit. That is the problem. And you must have seen the Venus Williams in between each games keep on drinking. She is a case of, she had admitted she is suffering from Sjogren's. You can have the Zika syndrome, Sjogren's comes alone, or you can come it along with the other diseases, like the association with the SLE and other things you can have. Scleroderma. It usually comes in association. Rheumatoid arthritis is a very common association with the SLE. Any rheumatoid patients, we can ask for the dryness of the mouth. Okay. Not only in the eyes or the mouth, wherever the exocrine glands are there, the sweating will not be there. The dryness of the nose, the dryness of the throat, the patient may have occasional cough. The patient also having a dryness of the vagina, dyspareunia is one of the commonest complaints for this patients. When there is a dryness is there, what happened to the teeth? Teeth get decayed. They cannot, dry fruits they cannot have it. Instead of because they need to for the swallowing the thing, they need keep on drinking. That's a problem. So what? These are all the symptoms. When you say somebody comes with a dryness of the, it doesn't mean that the patient is suffering from Sjogren's. 3 months is there for the diagnostic criteria to satisfy The dryness of the mouth or dryness of the eyes should be there 3 months. And 2 antibodies are there. The anti-Rho and anti-La antibodies. Otherwise called SSA and SSB. But you know the anti-Rho antibody, you have to test somebody is a pregnant lady with an SLE. Because the anti-Rho antibody will be positive, means that patient may be having the congenital SLE can be there. So the same antibody is there for here also. The dryness of the mouth can be there. Then the patient is taking the antihistamines, anticholinergic, antipsychotic drugs. Somebody is putting on the clonidine. This is a very common thing. The patient comes with the dryness of the mouth. So it can be there. So many infections can produce chronic conjunctivitis. You can have the dryness of the mouth. So many things can produce the dryness of the mouth. So how do you diagnose it? Because the Schimmer's test is there. The German scientist has discovered. Usually in 5 minutes, with a blotting paper, you keep it in the eyes and close it. You should have a 15 millimeters of the sweating should be there, 15 millimeters. If it is less than 5, you make a diagnosis of Sjogren's. Only thing is that the older age, when you go advancing the age, the dryness will be there. Not that patient, because this is occurring young female, so that doesn't come in the picture. Otherwise, as the age advances, you may not get this positive. What else you can do? You go for a biopsy. This is a parotid gland. These are the persons where a high risk of developing the lymphomas. There's a 40% chance of higher risk of developing. This is a parotid gland. You see, lot of cells are there. The germinal cell, lot of cells are there. So our patient, the anti-Rho, anti-La is negative except for the dryness of the mouth and the arthritis. So it is also not the case of Sjogren. So what else? This is a patient who present with the proximal, the weakness of the proximal upper limb and the lower. Patient cannot walk. That was there in the history. Patient cannot climb the stairs. Patient cannot get up from the chair. That means the patient is having the proximal muscle. There's a condition called the polymyositis and the dermatomyositis. This goes hands in hand. Okay. The polymyositis, the axial muscles, very close to the axial muscles. Okay. The deltoid, the supraspinatus, the sternomastoid, the platysma. The patient cannot hold the neck. Patient falls down. Patient cannot get, because the proximal muscles are the psoas, the iliacus, the pectineus, the gluteus muscles, the rectus, all gets affected. So they cannot get up from the seat. This is a condition called the polymyositis. It doesn't have a pain, unlike when you think of the ascites, means it doesn't have. This is symmetrical involvement. The symmetrical involvement is there. Then there is a destruction of the muscle fiber. There will be a elevation of the creatine phosphokinase will be there. The biopsy, you can diagnose that thing. You do the biopsy, you do the EFG, you make a diagnosis of polymyositis. The important thing is that the polymyositis patients are, polymyositis and dermatomyositis, both are at a higher risk of malignancy. You search for the malignancy in this patient. 25% patient will have a malignancy. You may be a colonic malignancy. In the females, usually the cervical malignancy can be there. So look for the malignancy of the lung, nasopharyngeal carcinoma. These are the things which may come across in this patient. You search for that things. Okay. And the dermatomyositis is same as the polymyositis. Nothing much is there. The patient has the skin lesions. You can see on the heliotropic rashes on the eyelids. You can have the lid edema, which can be there. You can have in the hands. It is called the Groton's papule is there. You should be the erythematous lesions. It is on the metacarpophalangeal joint and the endophalangeal joint. The erythematous, that's a Groton's papule. There's a shawls, and like what you put a shawl. You can have on the neck, there's a V-shaped lesions on the neck. These are all the things. But you are concerned, the patient may have having a dysphagia also because of the muscles start getting involved, the pharyngeal and laryngeal muscles gets involved. So you can have a, search for these patients for a malignancy things. There are 3 types of the antibodies you come across in this polymyositis. Anti-Jo antibody. These are the anti-Jo antibody positive patients are higher risk of developing malignancy. This patient can have a higher risk of And another thing is that SRP and antibody, you see the SRP. The patient can have the myocarditis. Cardiomyopathy can be there. The conduction defects can be there. And angio, and these are the two important things. MI2 is there, that will produce the dermatomyositis. Patients can have the MI2. When you do the biopsy, inside the biopsy, you see within the muscles, in the polymyositis, each myofibrils get involved, and in the dermatomyositis, it is in the periphery. Okay, that is getting involved. Okay. So, our patient had arthritis, the proximal muscle weakness, the angio antibody was negative, and nothing fitting with the connective tissue disorder in this patient. So, what we are left finally with the scleroderma. Okay. Scleroderma, you know, the patient may be having a good-looking young lady, found to be after some times they lost all the looks like a mask-like faces. The mouth will be very small, like a rat mouth. The patient's body will be all thickened. You cannot pinch the skin, and the patient may be having like a drawing of the hand. There's ulcers on the tip of the fingers. All disfigurement that happens there are two types of the scleroderma is there. One is a limited scleroderma, which is called the crust syndrome, where the involvement exactly limited to the elbow. It doesn't go beyond that. Exactly limited to the knee, not beyond that, and involvement of the face. That is called the limited scleroderma. Crust is the one thing. And another thing is the diffuse scleroderma, which involves the entire body. Entire body will be thick. The importance is this crust syndrome. These patients can develop a pulmonary arterial hypertension. So there you check for the anti-syndromal antibody, that will be positive. And these patients, diffuse scleroderma, they are more prone for an ILD. So the SCL70 will be positive in this patient. What we have mentioned, the first part is the right, that's autoimmune. Here, the involvement is the fibroblast. Fibroblasts started producing a lot of collagens. These collagens get deposited in the skin, in the dermis. That is why you get a thickness of the skin. And one more thing, you cannot pinch the skin because between the epidermis, there was a small amount of collagen was there, which disappears and everything goes inside. So whole things becomes the things here. Finally, you will get a red. When you put it in the basket of red hot water, it becomes red. That's the three things. This is produced by the occlusions of the blood, spasm of the blood vessels. Okay. The crust syndrome, you see the calcium can come out of the skin. That's called the calcinosis cutis. Then Raynaud's phenomena, already mentioned, the calcium deposits and sclerodactyly. Your hands will be like these things. That will be thick, it will be flexed at the metacarpophalangeal joints. And then the five things, calcinosis cutis, Raynaud's phenomena, esophageal dysmotility. Why the esophageal dysmotility? These collagens get deposited anywhere. Throughout the body, this gets collagen deposited. It deposited in the lower esophagus. Lower esophagus means the peristalsis won't happen. It gets in the stomach, it will have an airly satiety. Anything from the nose to the anal canal, anywhere this can get deposited. So one of the area is, that's why esophageal sclerodactyly and telangiectasia. And the esophagus, you can have the everything, okay. So what is the pathology happens over here? In the blood vessels, you can have the deposition of the collagens. So, two things are there. One is these patients can have the deposition of the collagen can produce the platelet aggregation, platelet derived growth factor can be the endothelin. Endothelin is concerned with the vasoconstriction. Normal person, if there is a more of a endothelin is there, it can get squeezed on this thing. And nitric oxide is there. That is a potent vasodilator. So level of the nitric oxide comes down and level of the endothelin goes up. So these two put together, there will be a spasm of the blood vessels. That happens in this patient. This is the pathology also happens in the lung also. When you talk about these things, you are concerned with the two things that is the cause of the death in this patient. When the patient develops the pulmonary artery hypertension, the survival is 2.8 years. That was the assessment. Okay, 2.8. We are concerned with the pulmonary artery hypertension. So you look carefully, is there that patient is having any evidence of pulmonary artery hypertension? There are 5 sites are there, the pulmonary artery hypertension. The first one is called arteriolar hypertension. Here the autoimmune, the primary pulmonary hypertension, the scleroderma and the autoimmune disease all comes under the arteriolar hypertension. That is called the type 1 hypertension. The type 2 hypertension, it is related to the left heart disease. Type 3 hypertension, it is related to the lung disease. And type 4 is a thromboembolic phenomena. And type 5, the miscellaneous like the sarcoidosis. All these things. But we are concerned with the type 1, I is concerned with the connective tissue disorder. Okay. The patient with the scleroderma, you look carefully for evidence of pulmonary artery. Look for the P2, loud P2, the parasternal heave. You look for the TR murmur is there, the JVP, SCV elevated, V elevation, JVP is there, and the pedal edema. Or look for any evidence. And you grade the pulmonary artery pressure. You can look for the mean pulmonary artery pressure by the cath, or you can do the systolic, mean systolic blood pressure. Okay, staging that things. Okay. Just look, get an X-ray done if the peripheral pruning is there or not. If prominent pulmonary artery is there, peripheral is very clear. The patient is having evidence of pulmonary artery hypertension. You look for an ECG. Is there any evidence of P pulmonary is there? Is there evidence of right heart overload is there? Is there an RVH strain pattern is there? New onset of RBB, anything is there, you look for. Then you will get a clue the patient is having the pulmonary artery hypertension. Okay, you go for the echo. You looking at the echo. You know, this is the peak, the tricuspid regurgitation jet. That is what you are seeing. You at the 4-chamber view, you put in the this thing, transducer. You see the jet. How much jet is there? If it is less than 2.5 meter, the patient doesn't have a pulmonary artery hypertension. If it is more, like 3, and there is a formula is there. You calculate the regurgitant jet velocity. That is, suppose it is 3 meter. You square it 3 into 3, it is 9 into 4. That is 36. That is the gradient between the right atrium and the right ventricle. You add on the right atrial pressure that you measure by the measuring the IVC thickness. Okay. So many, if you got in doubt, you send the patient to the cardiologist, see how much the correct velocity is there. And that is the first part. And second thing is we are concerned whether the patient is having the ILD. These are the two things. ILD, NSIP pattern is what you see. You just ground clearance appearance of the periphery. There is a bronchiectatic changes is there. These two honeycombing is there. Then you are sure that the patient is having the evidence. So the death of these patients are due to the pulmonary artery hypertension. So okay. So our patient have the scleroderma only, the Raynaud's phenomena only. No other things were there. So it is not a case of this. It is not a case of rheumatoid arthritis also, because rheumatoid arthritis now the criteria has changed. Now it is like this, the number of joints involved, you put a score. If it is more than 10 joints, you put a score of 6. If there is an anti-CCP is very high elevated, you put a score of 3. And duration as well as this. If the score should be less, if it is less than 6, you don't diagnose it. So that patient doesn't have a rheumatoid arthritis. So what is that? This time the patient was referred, the right person was referred to the right time to the right person. He was referred to the rheumatologist. It's a MCTD is a condition where you will have a bits and pieces. You won't have all this thing. He asked for one investigation only, anti-U1 RNP. If anti-U1 RNP is there, ANA positivity is there, the clinical features of all the other things is there, this is a case of MCTD. And our patient had the MCTD. So the last slide. So this is a usual one. If the patient is having, you can diagnose all the things with a single picture, what autoimmune disease the patient is suffering from. So what you need is referring the person at the right time to the right person, then you will save your hand and the patient will be saved. Thank you.